Mr. Francis is a specialist in hematology and transfusion. And so he is a master's degree holder, and currently he works with the Nairobi Hospital. And so he'll be taking us through from donor to patient, how effective donor selection prevents transfusion transmissible infection. As he comes in, we urge all to ensure that as you register, you key in the right information so that you can get your CPDs uploaded promptly when we are done with the process of this particular webinar. We also urge that to those who might be having complaints, you can still register your complaints through the WhatsApp numbers that we circulate in our alerts. You can also reach us through the complaint form that we also circulate in our alerts. We also will wish to encourage all of us that we visit our YouTube channel so that we can get more information on the different presentations we've been having throughout 2025 and the ones we've had in 2026. We also urge you to visit our Facebook page so that you can also engage us on different aspects of lab medicine. As we start, I can see our numbers are getting better, and so without wasting more time, allow me to bring in the presenter, who is Mr. Francis, so that he can pick it from here. Francis, are you able to hear me?
Yes, good evening. Am I audible?
Francis, are you able to hear me?
Yes, I can hear you. Am I audible?
Okay, thank you so much. Your volume is a bit low, but I think I don't know if our members are able to hear you well. Our members, you can let us know if you're able to hear Mr. Francis. Yes, we are also urging that as we proceed with this presentation, you can register your questions, your concerns under the Q&A or the chat section, so that at the end of this presentation, we'll be able to get some excellent questions and also some answers to them. Otherwise, the most important thing that we will be able to measure on today is on the donor selection as the first line of defense. And also, we also be able to understand that prevention starts before testing. And also we'll be able to know that strong systems is equals to safer patients. Otherwise, Mr. Francis, please go ahead.
Welcome, everybody. Thank you so much, Hatha, for the introduction. As been correctly introduced, I'm Francis Awino. Today, I'll be taking you through transfusion transmissible infections, where the topic is from donor to patient, which means if we don't capture this particular infections on time, we might end up actually transfusing blood with possible pathogens that would inflict infection on the patient, and this would result into morbidity and even mortality. So it's very important that we screen and do proper donor risk assessment. If we're able to do a proper donor risk assessment, then we'll be able to curb some of this risk and ensure that our patients are safe. Remember, transfusion should be of maximum benefit to the patient. And so we look at how effective donor selection prevents transfusion transmissible infection. So that will be answered in the presentation by looking at various recommendations. So what are some of the recommendations that the blood transfusion services have done to guide us when recruiting donors? So if you follow this one correctly in our work areas, or when selecting or rather recruiting our donors, then we'll be able to prevent transfusion transmissible infections to our patients. So this webinar is going to be based on WHO recommendations, because that one applies internationally. So it also applies to our setup, but the document is based on WHO recommendations on what should we look at when we are recruiting donors. So first, we look at the learning objectives. We need to understand what transfusion transmissible infections are. Those are pathogens those are infections that one is able to acquire when they receive either a blood component or blood product. And the second one, the role of donor selection in national blood safety. This is very key, because if we do it correctly, then now we are able to offer a safe transfusion and strengthening the donor to patient safety chain. So it really plays a key role in ensuring that our immunovigilance system is okay and there is safety at the end of the day. And now the patients are getting maximum benefit out of this particular transfusion. So what is transfusion transmissible reactions? One, the microbial agents of importance to our blood transfusion services are those that are transmissible by blood transfusion and can cause morbidity and mortality in recipients. So as we have said, the transfusion transmissible infections refers to microbial agents which are capable to survive in the blood products. And if by any chance we fail to detect them, they are likely to be transmitted to the patients via transfusion, and so therefore this can cause disease, that is the morbidity, and even death in worse scenarios. So what are characteristics of these microbes? How do they look like, or what are we looking at? So one, for these infections to persist or to rather able to survive in our blood products, one, the presence of the agent should be in one or more components of blood for long periods and in an infectious form. So they are in their infectious state, and they are able to survive in the blood components. So it could be in plasma, it could be in platelets, or it could be in red blood cells or all blood, depending on whatever we are transfusing. So the microbial agents should be able to survive in this particular component. And then the stability at temperatures at which the whole blood and blood components are stored. So most blood components are stored at 4 to, every blood component have their prescribed storage temperature. For example, red cells, 4 to 8. When you store your red cells at 4 to 8, the microbial agents should be able to survive. Then they are able to survive, then that's what qualifies them to be a transmissible infection. And then generally long incubation period. So some of them have got long incubation period that you might fail to capture at the Windows period. So even with the questionnaire, you might be able to, you might not be able to pick it due to Windows period, because they have got a long incubation period before appearance of clinical signs and symptoms that you can easily tell on a donor that this donor seems to be having this particular sign of HIV or syphilis, for example. But these particular infections have got a longer incubation period. So it means that your methodology, whatever you are using to screen these particular products, will matter a lot in helping you. So we need to use techniques that are of high sensitivity, techniques like ELISA. At least those ones will be able to detect infection in early phase. Then asymptomatic phase, or only mild symptoms in the blood donor, hence not always identifiable during blood donor selection. So they might not cause prompt symptoms that you can easily detect, maybe symptoms that you can easily see. So the donor might appear asymptomatic, and when they appear asymptomatic, you might fail to detect it at that particular point. And if we don't do proper screening, then we might risk transfusing our blood with these particular infections. So what does WHO recommend? So the WHO recommends at least a minimum of 4. So you must screen all the blood donations or other components should be mandatory for the following infections based on their markers. So we are supposed to screen for HIV, at least HIV, hepatitis B, hepatitis C, and syphilis, which means you can screen for more, but these are the bare minimum. In your screening panel for the transfusion you should not miss to screen your donors for syphilis, for hepatitis C, hepatitis B, and HIV. So the outcome of the laboratory screening of donations remain the final decision point in the release of blood components for clinical use. So that is why we are having the webinar, because we are all laboratory professionals. So the lab results will determine whether these blood products are going to be transfused or not. Yes, we've received the donations. It could be from schools, from university, or from a population or a voluntary donor who has just walked in. Yes, we have done the screening we have done the screening through the questionnaires that you give, and based on that, you have deferred some donors, but still that is not the final check at that particular point. We still have to go ahead and do the screening. So the screening result is what determines whether we accept that pint as a safe blood for transfusion. So therefore, the outcome of the lab will still remain the final decision point before you release the blood components. And that's why every blood component that we are going to release to be transfused in various wards or to various patients, or for those ones who are working in RBT, the ones that will dispatch to various hospitals for administration, they have to be screened for the bare minimum that we have said: HIV, syphilis, hepatitis C, and hepatitis B. However, even with high quality assays and system, it may still be ineffective because one, you might fail to detect the infection in the following donation in the window period. So the patient could be in the window period, maybe they have just gotten HIV and the virus in their system, yes, maybe less than 14 days, even with the laser, you might not be able to pick if they are in early phase of infections. Maybe 2 days, 3 days, 1 week, you might still not be able to detect that. And so therefore, that could be a risk to the patient. That's why we are also recognizing the fact that even with high quality assays and system, it may still be ineffective because you might fail to detect infection following donation in the window period. And so therefore, that's why you must do a proper donor risk assessment using the questionnaires. So based on the questionnaires, you should be able to ask the prospective donors whether, and based on the answers that they have given, we are able to see whether they have got high-risk behaviors. Maybe they have engaged in unprotected sex, things like that. They are using injectable drugs, things like that. So things that will expose them, to STIs and most commonly, and more important, HIV or even hepatitis. So if the answer is yes, then you will defer those particular donors, because they might be negative even at the screening, but you never know, they could be in their window period. So it is very important that we structure our questionnaire in a way that we are able to pick this particular risk real time and deal with and defer appropriately. So failure due to assay sensitivity or error, we are looking for shortcut. You don't want to do ELISA, you want to screen using the rapid test kit. You might not be able to pick those ones who are on Windows period. And then emerging infections for which screening is not available or effective. It could be a new infection or rather an emerging disease. It is transmittable through transfusion, but there is no screening. Maybe, like for example, a patient has gone to Mombasa. A donor traveled to Mombasa, they came back to Nairobi and they want to donate. They have been exposed to dengue virus, for example, and dengue virus is not one of the tests that you are screening, and so therefore you end up transfusing that to the donor. And the donor may be infected with an infectious agent for which the donation are not routinely screened. So the example that I've given from Mombasa explained that, because it is not part of the test that we are not routinely screening, you might miss to pick that. And so that's why we say it is very important that we consider, we review our questionnaires, because at least that one will be able to pick and rule out some infections. So the donor selection process may be able to identify and defer such an individual based on the symptoms or perceived risk. If it is fortunately enough that the donor is presenting with the symptoms, then you will exclude them based on those particular symptoms. So this is the donor risk assessment. I'll take you through on how you can do the donor risk assessment. And it is the first crucial step in the process of ensuring that the blood safety, as it helps significantly in reducing. So the reason why we do the donor risk assessment is just to ensure that we have significantly reduced the risk of transfusing infected blood to our prospective recipients. And this one can be done through deferral, where you defer these particular donors prior to donation of any individuals or groups of individuals with identified risk that may be associated with infections. Like, for example, where we have said, yes, we are not screening for dengue, but the donor have traveled to Mombasa, and they are even having symptoms like fever, things that could even resemble to malaria. Even malaria could not be a part of the panel that you are screening before. Or maybe the donor was infected with, they have just completed their treatment, or they are on treatment for malaria. You see such kind of donor, you are going to defer them. In some centers, they don't screen for malaria. But if you do capture that in your questionnaire, you will defer that particular donor until such a point where they are recovered fully from malaria. Then now you can admit them back to be able to donate. So that's how donor risk assessment is done. So you must understand the timing of infection is the most crucial in donor selection. So you must really understand what is the window period for those particular infections you are looking for, and then what is the incubation period. So the length of the window period is that time between the infectivity and the first detection of a defined marker of infection. So this one poses the greatest threat in the donation, because that is the point where you, even if you do the testing, especially if you're not using the right method, like you are using the rapid test kit instead of the ELISA technique, then you are likely to miss the population, the donors who are at they are infected with HIV, for example, and it is less than 3 months, which means that in their windows period, they have not already formed enough titer that will give you a positive reaction with the antibody. So if you don't take care of this, then you are likely to admit donors in their windows period. So this one poses the greatest threat in donation, and we really need to be keen on that. And then what is the incubation period? The time between the exposure to the infection and the onset of any symptoms of illness. Like for syphilis, they have got longer incubation. Yes, somebody might be infected with syphilis, but they might take a very long period before the symptoms actually start to appear. So the prospective donors should be asked relevant questions to assess their general health. So you should have a questionnaire where you are going to ask them general questions. So these questions will be able to will guide you to decide whether that's a healthy donor, because remember, we are not just taking care of the patient alone, we are also taking care of the donor. So it is a two-way traffic in that the donation process should be of maximum benefit to the patient, in that you prevent transfusing a blood that is infected with either HIV, hepatitis, or malaria, or any other transmissible infection to the patient. And at the same time, we are guarding the donor. Like, for example, the donor could be anemic and they don't know. And so that's why we need to do that pre-donation assessment. Or maybe the donor is they are expectant. They don't know that the people who are expectant are not supposed to donate, and so you will defer them based on that. So you will do the general assessment to assess the health status of the donor, and so that you only admit healthy individuals, and then any history or sign or symptoms that are indicative of current or past infections. So another thing, you also look at the high-risk behaviors, their travel history, their contact with infectious diseases, and possible exposure. So you'll also maybe they are not the one who are having this particular infectious disease, but they are taking care of those or somebody maybe who is having hepatitis B, for example. So it doesn't mean that they have got hepatitis B, the donor themselves, but they're at risk of getting hepatitis B, being that they are nothing those people with highly infectious diseases. So what happens in that case? You defer them for donation for at least 1 year, because at that point you cannot really tell whether they have been exposed or whether they are in the window period. So you would not really want to take chances in such a case. And so therefore, individuals who have engaged in behaviors that pose a high risk for HIV hepatitis B, and hepatitis C should be defined. So you should not assume as much as they are negative, but at least the behaviors, they have engaged in high-risk behaviors, including they could be sexual workers, they could be they are engaging in unprotected sex, they could be they are in the form they have indicated that they have suffered maybe STI, gonorrhea, or even mycoplasma or chlamydia, any of the STD infections in the recent past, then you have to defer them, because at that point you're still not so sure. Remember, that is high risk. They could be having HIV or rather hepatitis, but still in the window period that you might not be able to detect. So you defer even before you proceed with the donation. And then donor with infection risk, either due to being infected or exposure through sexual or household contact or those close contact. They say just as we have explained. So they could be potentially exposed to persons with highly infectious disease. It could be hepatitis. They could be having cared for. Maybe they're having their loved ones who are suffering from hepatitis B. I'll use that just as an example to explain. Or live with or had a direct contact with an individual with a suspected or a diagnosed infection. So this one should be defined. And you should also define them if they're having a symptoms of acute infection until they are fully recovered and they are no longer infections. So defer for 28 days if the incubation period is unknown. At that point where you are not sure of the incubation period, you defer for at least 28 days. So in non-endemic regions, deferral criteria may be applied to donors who have traveled or lived in endemic regions. Like, for example, you are working in Mount Kenya, you are working in Nyeri. Nyeri is non-endemic for malaria. And then someone in Nyeri traveled to Kisumu. And person X, they have traveled to Kisumu, which is endemic for malaria. And then, unfortunately, they came back, their mother or their brother is sick and need urgent transfusion. And then this person X, because they have just come back from Kisumu, remember they are not medic, so they don't know. Or even if they are medic, maybe they don't have this information. They have traveled to Kisumu and they want to donate. The patient is in Nyeri. Remember that Nyeri is a non-endemic region. So in such a case, you will defer this particular donor because you are not sure whether they have been exposed to malaria or not at that particular point. So deferral period may be extended if donors have had any diagnosed febrile illness during travel or since return from areas with, for example, dengue virus, like we gave the case of Mombasa, chikungunya virus, malaria, and Chagas disease. So we are going to look at particular transfusion transmissible infections, having looked at the donor risk assessment. Mostly the risk assessment, you'll do it through the questionnaire. So you have to tell us the questions that you are able to capture, the key things that you are looking at, because your major interest is to rule out whether the potential donor have got these particular infections or the potential donor have been exposed, or rather they are at risk of getting that particular disease. So you are ruling things. One, you are ruling at least three things. One, the donor itself have the disease, or the donor is at risk of getting the disease, or the donor is engaged in high-risk behavior. So if they are engaged in high-risk behaviors, then at that point, you cannot tell whether they are already exposed or not. So you have to defer that particular donor. So you have to tailor the questions in a way that you are able, you as a professional that is recruiting this particular donor, you are able to pick the answers you are looking for from the answers that they gave on those particular questionnaires. And that's why it's very important to always educate the donors. You don't just give them questionnaires and you stop there, because if you don't make them understand the significance of giving honest answers, some of them may end up giving false information, and you will be relying on that false information to either recruit or defer them. So it is good to let them know that this is a life-saving opportunity. As you are answering this question, you have to be as truthful as possible. Yes. So the prospective donors should be asked for a history of jaundice or hepatitis and whether they were further investigated to determine the cause. So in the questionnaire, you are asking for the history of jaundice, whether even in the household where they are living, there is someone with an history of jaundice. So you could use things like yellow. Are they able to see yellow eyes? Maybe in the people that they are in close contact with, or whether they have interacted with such a person. Maybe they don't know what jaundice is. But if you say, like now, you're asking them about the yellow eye, they could remember whether they have come into contact with such scenarios. So the blood transfusion service should ask if the donor currently or in the past has had a hepatitis infection. So apart from just being in contact, you also ask the donor whether they have been diagnosed with hepatitis, or whether they have received treatment for hepatitis before, and if they were diagnosed with any hepatitis infection, either B, C, or even A. Then assess any specific risk of exposure through sexual and household contacts, and also inquire whether the donor has had an hepatitis B vaccination within the last 14 days. So you'll also ask them whether they have been vaccinated, and if they have received this particular vaccination after how long, because you're supposed to defer those ones who have been vaccinated, or those ones who have received a vaccination for about 1 year. So individuals with the hepatitis infection may be asymptomatic or present with fever, nausea, vomiting. So these are some of the things you'll be looking at to guide you whether the patient is having signs of hepatitis or not. So they could be having fever, they could be having nausea, they could be having vomiting, loss of appetite, jaundice, abdominal pain, or an enlarged and tender liver if you do the physical examination. So one is hepatitis B, which is potentially life-threatening liver infection, and this is transmitted from human to human via blood and body fluids, not just blood only. It could also be through body fluids, and may be transmitted by transfusion and transplantations. Transplantation here, we mean the organ transplant, or via needles and other items exposed to blood, and from mother to child in utero and at birth or perinatally. So there we're just talking about the roots of transmission, and that's why, because this virus reside, or rather is in the blood, if we by mistake transfuse the blood that has got hepatitis B to the donor, it will be able, to the recipient, which is the patient in this case, the patient will be able to develop the hepatitis B infection following the donation, following the transfusion. So that's why it's very important that we screen our donors for this hepatitis B. And as you can see in the next bullet, it has got a very long incubation period of about 90 days. And this may vary from 30 to 180 days. So 90 days are like, how many months are those? Those are like 3 months. So you can imagine. So that's quite long, and you might not be able to pick it in window period, but it's always good that you do ELISA techniques. At least with that, you'll be able to pick it in early phase of, even in window periods, if the patient have already produced enough titer or antibodies in their system. So this may be first detected between 30 and 60 days after infection. But so you can see, if you use the rapid test kit, you might not pick it even at 30 days. That is within 1 month, you might not be able to pick it. Even at 14 days, you might not be able to pick it. But if you use the ELISA, you might be able to pick it as early as that. So infection in childhood commonly results in chronic infection more than 6 months. So mostly children who are infected with the hepatitis, they present as chronic and not acute. And this may be lifelong, or it could just resolve spontaneously at any time. They would just respond by immune system clearing the infection. Whereas infection later in life is usually acute. Like now in adults, if you were infected with hepatitis B, in most cases it presents as acute infection. Let me get back.
Yeah, Francis, seems to have lost you.
So
Yes,
I'm back.
Francis.
Sorry, something interrupted my network, but I'm back. So
Okay,
as
thank
I was saying, so hepatitis is life-threatening, and really one thing that we cannot joke with. So we really have to ensure that our donors, that's why the questionnaire should be structured in a way that we are able to capture. And you can't ask people directly, are you having hepatitis? They will say no, but some of them do not. But now when you use things like the symptoms, like we said, whether they, maybe themselves they have seen the yellow color, they have interacted with the patients or persons with yellow color in their eyes. You see, with that, something that is unique. So somebody is got they would be able to remember fast. But of course, if they have been diagnosed with hepatitis, they'll be able to answer. And again, you engage in activities that would you also try to look for activity that is able to expose them to this particular infection. Like, for example, they are engaging in unprotected sex, they are using injectable drugs, things like that. So you look at high-risk behavior. Like some of them, they could be sexual workers, things like that. Those ones are high-risk behaviors. And you also look at whether they have been exposed to whether they have been in contact taking care of someone who is sick and has got a known diagnosis for hepatitis. So through that, the questionnaire will be able. So what does the blood transfusion services recommend? For hepatitis 1, the following may be accepted for blood donation provided they have been tested and found to be negative for hepatitis B surface antigen. So they are negative for hepatitis B surface antigen, then you accept them. And negative for they're also negative for anti-HBs, that is the anti-hepatitis B surface antigen. This one you will this one for people who have not been exposed, which means they have not been exposed to hepatitis, the general population. They have not been exposed to hepatitis B, and so therefore they're negative for the surface antigen. They will also be negative for the core antibody as well as the surface antigen. But there are those ones who are who have received vaccinations, and so therefore they have developed the anti-hepatitis B surface antigen, or rather they were exposed to hepatitis B, and then in the process it was chronic, so the body was able to clear, and they have got anti-hepatitis B surface antibody in their system. So for vaccination, at least there should be indication that they are protected against hepatitis B, and the titers should be at least 100 milli international unit per mil. So individual with a past history of HBV, if more than 12 months ago, they have got a past history, maybe they were in contact with people who were exposed or people who were diagnosed with HBV, but it has lasted for more than a year, you can accept them back to donate. And then current sexual contacts of individuals with a history of HBV infection, if more than 12. So those ones who have come into contact with persons with HBV infections, you only accept them to donate if it has lasted for more than 12 months. For current and former household contacts who have been successfully immunized against HBV and are anti-HBs positive, and more than 100. So these ones, they have, if you test the core antibodies, is negative, but for the anti-HBs, it's positive. However, the titer should be greater than 100. They were in contact. So this contact could mean they got infection at that point and their body responded by producing the antibodies against hepatitis, or rather they got the vaccines now because they were at risk of the infection. And if that is the case, for them to donate, you need to have that record. At least the titer should be above 100. So donors with initially reactive result for hepatitis B surface antigen but confirmed to be non-reactive, re-entry procedures. So in such a case, you will follow the protocols that are set up. So when do you defer these particular donors? So for hepatitis, individuals with active hepatitis B infections or a history of infection. Also those ones with current sexual and household contacts of individuals. with active HBV infections. Like, for example, the ones who are currently taking care of patients, or rather household contacts with people who have been diagnosed with hepatitis B. We are not going to admit them as donors. And the people who have been diagnosed with the infection also, we don't admit them as donors. And then former sexual contacts, even if it is not current, but in the history previously, if they can remember the people whom they had sexual contacts with had active HBV infection, you defer for 12 months since the last sexual contact. For in such a case, if they can remember, then you ask them, when likely did you had sexual contact with such a person? And then now you count from that point for 12 months. They have to be deferred for that long. And then former household contact, the same case applies also for the household contacts. Maybe they were taking care of their sick loved one, and even maybe the loved one died. So in such a case, you still defer them for 6 months since the last contact. So health workers who have suffered an inoculation, so also the health workers, they want to donate, but at one point in their duty, duty, they suffered an inoculation, or rather needle stick injury or mucosal injury. You defer for 12 months following the exposure, and the health workers who have been vaccinated against HBV should be assessed individually. Again, those ones you defer for 12 months. So that's all about hepatitis B. We look at hepatitis C. It's also a liver disease which is caused by the virus hepatitis C. And this is mostly transmitted through the exposure to infectious blood. And that's why we don't want to transmit a blood that has got hepatitis C, because it will cause the similar infections to the patient. And this can occur through contaminated blood transfusions, the blood products, and even the organ transplants. So injections given with contaminated syringes or even needle stick injuries in healthcare settings like we are doing, like us who are working in the healthcare industry, also can expose to the same. So in the ones which are using drugs, so injecting drug use or being born to a hepatitis C infected mother. So it could be a small child, a small baby who have been diagnosed with hepatitis C. They have been acquired through the mother who was suffering from the same. And so therefore hepatitis C may also be transmitted through sex with an infected person or sharing of personal items contaminated with infectious blood. But this is a rare case where in that case of sharing personal items that could be contaminated, it is a rare case, or rather a less common occurrence. But sexual contact, that is common, and we have to take care of that. So the incubation period for hepatitis C is between 2 weeks to 6 months, and you can see they can have longer incubation period, and that's why we need to screen our units for hepatitis C. Because if we just go by the form alone, we might not be able to pick the ones who are on window periods, and maybe they have not even started showing any signs of symptoms, or rather clinical symptoms. So following initial infections, approximately 80% do not exhibit any symptoms. So in most cases, the people who have got hepatitis C, at the early phase of infection, they don't show any symptoms, and about 75 to 85% of newly infected persons will develop the chronic disease for this particular virus. So you can imagine that even the donor themselves, they might not know they are having hepatitis C until now you are giving them the result. Because remember, if anything is reactive, you're supposed to get back to the donor. It is a two-way traffic. The donor should benefit out of that process. And how are they going to benefit? When you tell them the results and ask them to seek medical care, or rather attention from the qualified personnel. And so therefore, what is the BTS recommendations? You accept household contacts of individuals with HCV infections, but you defer the current sexual contacts of individuals with current or past HCV infections. So if the donor indicates that yes, they have had sex, or rather sexual contacts with individuals who have been diagnosed with HCV, either in the current month or in the recent time, or even in the past, if they can remember, you defer them. Former sexual contacts of individuals with HCV infection, you defer for 12 months since the last sexual contact. Health workers who have suffered an inoculation or mucosal injury, you also defer for 12 months. And then the ones that you defer permanently are those ones who have got current or past HCV infections. With them, you defer permanently. So the third one we're going to look at is HIV, and this can also be transmitted via unprotected and close contacts with a variety of body fluids of infected individuals. It could be body fluids such as the blood, the breast milk, semen, and vaginal secretions, but cannot be transmitted through ordinary day-to-day contacts such as kissing, hugging, shaking hands, or sharing personal objects, food, or water. That one we all understand. I don't really want to go much into that. So high-risk behaviors. So what are some of the high-risk behaviors? Because this is our interest as transfusion, people who are working in the transfusion area. What we are trying to curb this particular infection. And so therefore get as much clinical information as possible that will enable us to define these donors appropriately. So one is having unprotected anal or vaginal sex, having another sexually transmitted infection. So they could be having another STIs like herpes, chlamydia, gonorrhea, or bacterial vaginosis. And if you remember last year, there was a presentation on HIV, and we saw the reason why we defined them is because these particular infections, most of the cells, the immune cell that is recruited to the entry site, that is the genitalia, is the CD4 cells. And the CD4 cells is what HIV mostly target. And that is what put these people at risk of getting HIV. And then sharing contaminated needles, syringes, and other infected equipment and drug solutions for injecting drug use. So again, those ones who are sharing needles, you could suffer even a needle stick injury. That could be also but now we are looking at a high-risk behavior. So high-risk behavior, which means this is what they are doing. This is what they are practicing. They are sharing contaminated needles. They are injecting themselves with drugs. So in such a case, they are at high risk. And if they really confirm to the form that they are practicing or rather engage in such activities, we defer them. Next is receiving unsafe injection, blood transfusions, or medical procedures that involve unsterile cutting or piercing. So it could be tattooing. We are not sure on how they handle the equipment that they are using in whichever places they go for the tattooing or even piercing of their bodies. And so therefore that could also be expose them to this, expose them to getting HIV or any other infection. And then experiencing accidental needle stick injuries, including among healthcare workers. And then infectivity estimate in case of transfusion of infected blood products are much higher, around 95% than for other modes of HIV transfusion, owing to the much larger viral load per exposure than for the other routes. Remember, in transfusion, you could be transfused even with 3 pints, 4 pints. That is a lot of blood. So if you are given even 1 pint is having around if it is whole blood, we are talking about 450 ml. If it is packed red cells, it could be 300 or so. So you can imagine that is quite a lot. And if this donor was having high viral load, then chances are very high that the patient is likely to be infected with the HIV following the transfusion. And I hope through that you are now getting why it is very key that we screen our donors for this particular infections. So number one, household contacts of individuals with HIV, you accept. You don't defer donor simply because maybe their household, in their household, one person or another is having HIV. You don't defer in such a case. You accept them. Then when do you defer? Current sexual contacts of individuals with HIV infections, or rather former sexual contacts of individuals. So those ones who are currently in sexual contact with persons living with HIV, you defer. Or also those ones who have had sexual contact with persons living with HIV, you defer for 12 months since the last sexual contact. And then the ones who defer permanently are individuals with the present or past clinical or laboratory evidence of HIV infection. So these ones have been tested and confirmed to have HIV, and therefore in such a case, we will defer them permanently. So when we are done with HIV, I know this one we don't screen routinely, but it's also one of the infections that can be transmitted through blood, and that is the human T-cell lymphocytic viruses. They are present in the bloodstream in lymphocytes. So this mostly, it might only become an issue to immunocompromised patients. And I know with the epidemiology, if you look at the trend of cancer, it continues rising in our country. And so therefore, even in our hospital setup, we will have this kind of patients who are immunocompromised, and not even just cancer alone, even the patients who are suffering from the ones who have gone organ transplant, those ones are immunocompromised, and they're also on immunosuppressive drugs, so that they're able to accept. And so if a virus like this gets to a patient, the patient who is on immunosuppressive drug, or rather they are transplant patients, chances are very high they will be infected with this particular virus. So non-cell associated virus is rarely found. So if the cases are rare, the infectivity of blood and blood components is reduced, but not removed by. So leukodepletion it doesn't completely remove it, but what it does is that it reduces the infectivity. Because what are we doing in leukoreduction? We are in leukoreduction, for example, or leukodepletion. We are removing the white cells, that is the lymphocytes. So we remove them as much as possible, and mostly. So don't do injustice to patients who are immunosuppressive, especially those ones who are organ transplant patients, or even patients who have suffered cancer for long and their immune system have really deteriorated. We're supposed to give them leuko-reduced products. By doing that, at least you will prevent them even from things like HLA. Because HLA, so rejections, the transfusion reactions, you will really help them. You will really help them by not developing these particular rejections. And so therefore, HTLV can be transmitted from mother to child also, primarily through breastfeeding, and it may also be transmitted through sexual contacts. So as infection is considered to persist for life, screening for anti-HTLV identifies donation that may transmit HTLV, but not in itself indicate the time scale of an infection. So in such a case, you might have to screen, but I know, because now we are in a setup where you might not be able to screen for HTLV. So the best you can do is to give the leukoreduced platelet, and if they are organ transplant, especially the patients who have received stem cell transplant, you can do irradiated products. So accept household contacts of individuals with HTLV. That is now in blood transfusion recommendation on what you should do in case of HTLV. And then individuals whose mothers or maternal grandmother has or had HTLV infection, if blood screening for HTLV1 infection is available, then we're supposed to admit them. So if they have got exposure to the same and you are able to screen and it is negative, then you admit. Then former sexual contacts of individuals with HTLV if more than 12 months after the last sexual contact. So when do we differ? Current sexual contacts of individuals with HTLV1 and 2 infections. So they have the possible evidence that they have got HTLV infections, you differ. Former sexual contacts of individuals with HTLV1 and 2 infection will differ for 12 months after the last sexual contacts. When do you differ permanently? Individual with HTLV1 and 2 infections, individual whose mother or maternal grandmother has or had HTLV1 and 2 infections, if blood screening for HTLV1 and 2 infection is not available. And former sexual contact of individuals with HTLV1 and 2, if again you are not able to screen for the same. So another one we look at is dengue and chikungunya virus. So are transfusion transmissible mosquito-borne arboviruses, and both give rise to acute infection with no chronic infection. Infection with dengue virus can have very serious, so for dengue, it could have serious implications. And although both are potentially transmittable, there have been no proven cases of transmission of chikungunya and relatively few reports of transmission of dengue. So the cases where we are having dengue virus through transfusion are very rare, but that one does not exclude the fact that this one can happen. So blood transfusion services in non-endemic areas wishing to exclude at-risk donors should include questions about travel history during the donor selection process and maintain up-to-date knowledge of disease epidemiology. So that will also guide us on how we tailor our questions in the questionnaires. Because again, let's say if this setup was in, let's say like Mombasa, where it is endemic. If it is in the coastal region, then when they are recruiting for donors, they will have to screen for either dengue or chikungunya virus to prevent transfusion of the same to the potential recipient. But if you are in low-risk areas, like non-endemic areas, maybe you are in Nairobi, for example, then you have to include the travel history as part of the questions. And now, if you include that, we'll also ask them whether they have been diagnosed with the dengue or before or not. So the BTS recommended recommendation on chikungunya include one, and for endemic areas, individuals with a history of dengue or chikungunya virus, you defer for 6 months following full recovery from infection. So if you are working in Mombasa, for example, and the patients have been diagnosed with, the donor, not the patient, sorry, we are used to patient. The donor confirmed that they have suffered from chikungunya virus or dengue virus, for example, you defer them for a period of 6 months since the date of full recovery. For the non-endemic areas, individuals who have visited an area endemic for dengue or chikungunya virus, you defer for 28 days following return. And if they have got febrile illness during or following return from an endemic region, you defer them for 6 months following the recovery from infection. So maybe they have gone to the coastal region, they have returned, and now they are having febrile, and they have also come to donate. And you even check with the temperature, you've seen they have got a very high temperature. So in such a case, you defer for 6 months. So we'll also look at malaria. Malaria is also one of the protozoan disease that can also be transmitted via blood transfusion. And this could be through donation collected from asymptomatic parasitemic donors. So the parasite is released into the bloodstream during its life cycle, and it will be present in the blood of individuals who are infected with the malaria. And so therefore the parasite is stable. So one thing that we need to know, the malaria is stable in plasma and all blood for at least 18 days. And now if it is stable for that long, then you can see we are likely to, it is likely to cause a transfusion transmissible infection in the potential donor. So when stored at 4 degrees Celsius and for extended periods in a frozen state. So you can even see in plasma. In plasma, for the frozen plasma, you can also still get through that. So donor selection criteria is to exclude the collecting blood from individuals with current or past history of malarial infections and at risk of transmitting malaria through transfusions. So this should be based on local epidemiological evidence and endemicity of the infection, just as we had said, just as we had explained in the case of Nyeri when we are starting. Someone has traveled to Kisumu, and so therefore they could be exposed. So when they go back to non-endemic region, like in the Mount Kenya region, then now these particular people should be deferred for donation at least for some days. So the endemic areas, what should you follow? The donor selection and the deferral strategy should be developed to identify individuals with evidence of current malarial infections and defer them for a period of 6 months after the symptoms. That is fever with rigors or on completion of treatment and full recovery. So you will assess that whether they have recovered fully, and if they have not, you defer them for 6 months. And alternatively, the blood transfusion services should screen all donation for parasitemia using thick blood film or for evidence of malarial antigen using a highly sensitive enzyme immunoassay. So this is even the most effective way that we can have it. So we also include malaria in our screening panel. So if you include malaria in your screening panel, you can either do it through a test smear or you can use RDT to screen for the malaria. And then for non-endemic areas, malaria is increasingly a matter of concern to BTS in non-endemic areas. So you can imagine if you transfuse a patient in Nyeri, let me use Nyeri and stick to that. If you transfuse a patient in Nyeri with a blood that is having malarial parasites, will be doing more harm to that patient, because which means there will be hemolysis following the malarial infections. And remember that the immune system, they are not partially immune to malaria, and they could suffer severe malaria in the process that could even worsen whatever they were treating in that case. Yeah. So the blood transfusion services in the endemic areas, the endemic areas should develop, number one, donor selection criteria to identify and collect blood from donors at the lowest risk of infection. So during the malaria season and during the rest of the year, and then strategies to maximize the collection of blood from donors from geographical areas with low endemicity, which could not be practical, for example, in people who are situated in Kisumu and they need blood. So that would not be really practical. So what would we do if they're in those areas? The best thing is to screen the donation that we are receiving for malaria, so that the ones which are positively excluded. So defer individuals with a recent infection with malaria. You defer for 6 months after completion of treatment and full recovery, whichever is longer. In an endemic areas, define the donor population with a risk of exposure to malaria and thus the potential for transmission through blood donation. Also implement donor selection and deferral strategies to identify individuals with a recent history of malaria or specific identifiable exposure risks, such as travel to malaria endemic zones. So these donors should be defined for a period defined by the country. So this is done based on specific countries. I said these recommendations are based on WHO, but now WHO is looking at the whole world. So which means that it cannot apply the same across the world. And again, even in Kenya, as we are giving example, we see the recommendations we'll give to Kisumu is not the same recommendation we are going to give to RBTC that is located in, let's say, in Nyeri, or maybe even in coastal Kenya. Coastal Kenya could be same as that of Kisumu because of the endemicity. And so that's why we say when we are in the transfusion chain, we need to be well updated with the malarial, the trends of these particular infections, the epidemiology, because that again will engage even, will shape even how we recruit our donors. So the questions, prospective donors, one, you will ask them about the place of birth, the previous residence in endemic areas, whether they have lived in malaria endemic zones, they have traveled during the previous 12 months, history of malaria or any undiagnosed febrile illness during or after visiting an endemic areas. If you go to, in other countries, they would defer persons who have been diagnosed with malaria for as long as 5 years before they can qualify to donate. So when do you defer? Individuals so if sensitive and multi-specific antibody screening are not available. So in such case where you are not screening, you defer your donors based on this. Those ones who have traveled to malaria endemic areas and who have had no symptoms, you defer for 12 months from last return from the endemic areas, because you are not screening. So you can't, you are not able to detect whether they're having malaria or not. Then they have traveled to malaria endemic areas and who have had febrile symptoms but not diagnosed as malaria. You also defer for 12 months following full recovery or last return from an endemic area, or whichever is longer. The ones who have lived in malaria endemic area in the first years of life or for continuous period of 6 months or more defer for 5 years after last return from a malaria endemic zone. But that is not applicable for the Kenyan setup. That is applicable for other countries where malaria, the epidemiology there is as low as 1% or so. Because if you defer in Kenya, if you're going to defer donors for 5 years simply because they have traveled to the to Kisumu or other endemic, we will not even have donor to recruit, because there is a lot of activities and people keep moving and transfer and all that. So as you understand that. So as we had said, epidemiology is very important when making this particular decision. So defer permanently individuals who have ever had a diagnosis of malaria. Is that practical in Kenya? It's not practical in Kenya, but it could be practical in other countries where the malaria infection is as low as possible. And so even people who have had malaria in the whole population could be less than 1% of the population. So it means that even if you defer that 1% permanently, you are still able to recruit donors in the 99% of the population that is remaining. So in where you have got sensitive and multiple multi-specific antibody screening tests, the RDTs, multi-specific, are those RDTs which are able to pick PF, they're able to pick malaria and other malarial species. So you accept a symptomatic individual with identified malarial exposure risk, so for example, travel or residents, or residents, you accept if more than 6 months after their last return from the endemic area. But however, you will defer the ones which are identified. They have traveled and work on a sim. I mean, they have got no symptoms. You defer for 6 months after their last return. Identified malaria exposure who have had febrile symptoms but not diagnosed as malaria. Again, those ones you defer for 6 months from cessation of symptoms or last return from the endemic region. A current infection or history of malaria defer for 3 years following completion of treatment and full recovery. So for malaria, it's highly debatable. For our setup, what I would advise is we incorporate malaria as part of the screening panel for the TTIs. Maybe that way we'll be able to help go a long way. Because again, if you screen the blood that's donated, for example, in KNBTS, for example, and 90% of them will be malaria negative. And so there you will still have products to give. It could be 1 or 2 pints that are turning positive. So not that you will really do much. It will give you a similar pattern as syphilis, HIV, hepatitis, and the rest. Yeah. So the risk of transmission of, we're not talking about the syphilis, the yaws, and the gonorrhea. So those are the STIs that are also could be transmissible via blood transfusion. So the risk of transmission of syphilis, for example, the T. pallidum through the transfusion of processed and stored blood is low, as the spirochetes are released into the blood cell only intermittently during the course of infections, and they are destroyed within 72 hours of storage at 4 degrees Celsius. So, however, it is possible to acquire the same via transfusion, but the chances, or rather the probability of having that, is very low, and due to that explanation. One, we have said they're destroyed within 72 hours when the products are stored at 4 degrees Celsius. Second, we have said these viruses are only released during the infection. However, the T. pallidum can be transmitted through fresh bloods and platelets. So it is possible to transfuse the same through the fresh blood and platelets, and it is not transmitted by plasma products or fractionated plasma products fractionated from food plasma, such as factor VIII. So another one is your or Treponema pallidum pateni, which is not transmitted through the transfusion, but is serologically indistinguishable from syphilis. So the serological test for syphilis may remain positive again for many years after successful treatment. And then the causative agent for gonorrhea, that is the Neisseria gonorrhoeae, is not transmissible by blood transfusion. But nevertheless, most blood transfusion services defer individuals with gonorrhea for 12 months, and we had explained this because they are at risk of, as much as this is not transmitted via the transfusion, but they are still at risk of getting HIV or other TTIs. So what are the recommendations? Household contacts of individuals with syphilis, these ones we will accept, but we will defer those individuals which are current sexual contacts of individuals with syphilis. Those ones we defer. And then they are formally, in the past, they have been in sexual contact with individuals with syphilis. You defer for 12 months since the last sexual contacts. Individuals with gonorrhea, again, defer for 12 months following completion of treatment and assess for high-risk behavior. And then the current sexual contacts of individuals with gonorrhea, we defer. Former sexual contacts of individuals with gonorrhea, we defer again for 6 months since the last sexual contacts. And then the people who have been diagnosed, or are rather, have had a confirmatory diagnosis for syphilis, you defer permanently. And then finally, we might conclude by looking at a sample of a questionnaire on how the risk assessment is done. So this questionnaire, for example, if you look at this, the first question there is your reason for donating blood to undergo an HIV test? Then the donor will either tick yes or no, if that is the reason. Then if yes, have you ever been tested for HIV? So you ask the donor whether they have ever been tested for HIV. If yes, what was the reason for testing? Was it voluntary? Was it employment? Was it insurance? Was it medical advice? By that, we're just assessing the whether the donor is also concerned about their HIV status. It could be maybe they have never tested for HIV the whole of their life, or they tested for the first time because it was a requirement for employment, or it could be a requirement for insurance or even medical advice, which means they were persuaded medically to do the same. So have you ever had casual or oral or anal sex with someone whose background you do not know, with or without a condom? So see, if they say yes, then it means that is a high-risk behavior. For such a donor, we are going to defer. And then have you ever exchanged money, drugs, goods, or favors in return of sex? If they said yes, then again, that is a high-risk behavior. Because then have you suffered from a sexually transmitted disease, syphilis, gonorrhea, genital herpes, genital ulcers? Again, if they say yes to that question, it is a high-risk behavior. So such a donor, you will defer based on the guidelines. In the past 12 months, has there been any change in your marital status? If sexually active, do you think any of the above questions may be true for your sexual partner? So again, you ask them, maybe, so this time we will know whether they have been in contact, because again, if 22.7b is true, which means they have clicked yes, then again you will go back, which means this particular person, as much as they have not been exposed, but they were, I mean, as much as they don't themselves, they have not they are not confirming that they have had this particular activity, but they are confirming that they have been in contact with a person with syphilis, gonorrhea, genital herpes, and genital ulcer, and that is a high-risk behavior. So therefore, again, we define this particular donor. So have you been a victim of sexual abuse? Again, if they have been a victim of sexual abuse, it is not a high-risk behavior. And I'm not saying they are doing that voluntarily, but again, they are at risk. So again, that is a high risk. They are at high risk of getting HIV, or rather other STIs again. Because again, if they are a victim of sexual abuse, it means they don't know the status of the partner, of the person that committed that particular crime. So have you or your sexual partner suffered from night sweats, unintentional weight loss, diarrhea, or swollen glands? We are just trying to give some of the symptoms. If it is yes, they say no, this could be symptoms to HIV. This could be symptoms to hepatitis. So again, if it is yes, then you defer this particular donor. Have you ever injected yourself or been injected with illegal or non-prescribed drugs, including bodybuilding drugs or cosmetic, even if this was only once or a long time ago? So see how that question tried, even if they didn't do it currently, but maybe they did it in the past. So that last part is just to trigger their memory, to see if they can remember the chronological of events. And if it is yes, then at that point, we are not able to recruit this particular donor. Then have you been in contact with anyone with an infectious disease, or in the last 12 months, have you had any immunization, vaccination, or jabs? Again, you'll ask about the vaccination status, because again, if they have received vaccination, then you defer them based on the guideline for those particular vaccines. Then have you ever been refused as a blood donor, or told not to donate blood? So that's also important. If they were deferred, then what was the reason for the past deferment? Then now you see if that is resolved or not. And that brings us to the end of our today's presentation. If you follow the various recommendations for various infections, especially the bare minimums, they be able to recruit these donors in a way that we are preventing the transfusion transmissible infections. So the key thing is just to have a look at our questionnaire, whether our questionnaire has got questions that will help us to do donor risk assessment appropriately, and so that we are able to defer these particular donors appropriately. And then again, implement the screening part of it, whether we are doing the screening effectively and we are using the right techniques for the screening, so that we are able to pick these particular infections. Even when you see the screening is the second guard, which means we are, I mean, maybe the information that we are given in the questionnaire are still not able, we are still not able to to defer those donors based on that. And so therefore we went ahead and recruited the donor. Then after recruiting the donor, we have collected the blood. So we have the blood in the lab, and now we have to give the blood to the work. So you screen before you give the blood to the patient, and then now we have screened, and one of the TTIs is positive, and we stop there. Which means you discard that particular blood, but again give the information back to the donor so that they receive the necessary medical attention or rather treatment in case they are diagnosed with any of
Francis, we seems to have lost you. Are you there?
Yes, I'm there.
Okay.
Yeah, so we are done.
Okay, thank you. I think for this insightful presentation, we've learned a lot. I'm able to see Professor Tom Were. He is in the webinar. I don't know if he is in a position to maybe make a comment. I've given him the mic. I've given him the mic. Professor Tom, are you in a position to make a comment? Because I know you are a specialist in this area of hematology. Are you in a position to make a comment? Probably he'll come later, but we can go through our Q&A section and see the questions that we have. The questions that we've received. The first question, the first comment came from Prof. Tom Were. He says, "Good evening, everyone, from the Department of Human Pathology, Masinde Muliro University in Kakamega. We have Alvin Kinji. We have Alvin Kinji. He says, this is such an excellent presentation. Is it possible to have a standard questionnaire that is acceptable and universally utilized everywhere for assessing risks of infectious diseases among donors according to the set standard guidelines?" You can tackle that, Mr. Francis.
It is possible, and I know there is a gap country. Maybe the policymakers, I know in the webinar, you might be having one or two policymakers on board. So the only way that we are going to achieve this as a country, I'm not talking as Kenya, is having a proper hemovigilance system. So this proper hemovigilance system should be implemented right from the dispensary all the way to the national referral hospital. In that the bodies can BTS, the Kenya National Blood Transfusion Services, is able to come up with one structured questionnaire that can be used across all the blood donation centers. So this one structured questionnaire, the only customization that could be made is maybe based on the epidemiology, as we have alluded in the presentation. So based on the endemicity, let's say for Kisumu, how you will recruit donors on malaria section, for example, will be very different from someone working in Mount Kenya. So maybe with just some few exceptions here and there, which is possible through the regional office. So if you have one structured questionnaire from the KNBTS, then we can achieve this. And then if the KNBTS can have a hemovigilance system in a way that they are able to regulate all the donation centers. I know there's so many donation centers that those ones which are hospital-based. So those ones should be included because there we might not have challenges with the RBTC. At least with them, they are working with one structured organization, and or even their documents are uniform, right from the satellite to the. But what about the small hospital? I mean, what about the small centers that are domiciled within the hospitals? So maybe that is another thing that the KNVTS need to look at. So before they give a go-ahead to an hospital to actually act as a donation center, which means they can accept donors, bleed them, and process these particular components, they need to go a formal assessment, like that one can TTB do for registration. A formal assessment to ensure that they have got the required resources. Maybe they are doing donation, but they do not even have machines that are doing ELISA. So they'll be telling you that we are sending to, and you see with that, you cannot really confirm whether they are truly sending those samples to labs that are doing ELISA or not. And some of them might just end up screening with the rapid test kit and not the required. So it's an area that requires a policy framework that need to be worked on nationally, and then it can be implemented across years.
Thank you for that response. We have Emmanuel Kipleting, and Emmanuel Kipleting has a question. The question goes, why is the blood from individuals with gonorrhea rejected, yet gonorrhea can't be transmissible through blood transfusion? Back to you, Doc.
So in the presentation, we've also highlighted clearly that yes, as much as gonorrhea cannot be transmitted through transfusion, these individuals are at risk of getting HIV. They're at risk, especially, let me use HIV as an example. They're at high risk. The people with STI, that is a high risk behaviors. So the fact that they are having STI, it means that it is a high risk activity. I mean, they are in that group of high risk activity. And so therefore, that is why they are deferred for 12 months. Yes. Because you might assume, and what is able, I mean, the infection that is current at that particular point of testing gonorrhea was gonorrhea. That is what we could pick. But this, apart from gonorrhea, there is an HIV and the patient is in the Windows period. And all the tests have turned negative in the Windows period. I mean, the HIV is negative, and so therefore you want to give that particular blood. But in real sense, they have got the virus in that blood. So to avoid that, that's why they are deferred. And not just gonorrhea, we said even other STIs. Mm-hmm.
Yes, there's also another response from Felix Nganga, and he says, gonorrhea may be indicative of co-infection with other blood-borne pathogens in the window period. So that could be the reason why one who has gonorrhea can also be rejected. Once sample once the donor is a gonorrhea patient, then the sample merits rejection. We have Ferdinand Griffin, and he says a very good presentation. Actually, it's good we keep an eagle eye on TTIs for safe transfusion. And then we have Moses Gikungu, and he has a question. It goes, it's such a wonderful presentation. Is it this test HTL V1 and 11 available in, and V1 and 2 available in our regional blood centers? Back to you.
This one I know, not just the regional transfusions, and I know it is not available in most facilities. I'm not sure whether KNH is doing it, but I know it's one test that might not be available. So that's why we say that as much as we might not have the screening tool to, as much as we might not have the tool to screen for HTLV, it is good that we know, we understand our recipient. The key thing here is the person who is going to receive the blood. Let's understand our recipient better. Then maybe even the existing questionnaires doesn't even have a question on HTLV. So that is another thing that we can look at. But what we can do at our level, the best we can do, we give those recipients who are at risk of HTLV, like the ones who are immunocompromised, cancer patients, the organ transplant patients, the stem cell transplant patients, those ones who have organ, of course, that their kidney is there. So let's give them leukodepleted products, because due to the resource poor setting that we are in, we might not be able to give them the best for them, and the best for them is the irradiated blood products, because with the irradiated blood products, you've already destroyed all the lymphocytes, and even if there was HTLV, that blood will still be safe. Yeah.
Thank you. Colin Soyo has a question, and the question is, do alcoholics pose any risk as far as donor selection is concerned?
Not sure if it poses any risk as much as donor selection is concerned, but I think the reason why they are normally defined is you could not tell whether the concentration of the alcohol in their system. Yeah, so that's why at least you defer that donor who is who have yeah, in that question is there. That one is there, whether they have taken alcohol in the past 2 days, in the past 48 hours, things like that. Then you defer them, because again, somebody could be intoxicated midnight. You don't know how many bottles they drank, and the alcohol is still in the system, so you'll end up transfusing the same. But that one will not give any transmissible infection.
Yeah, very well. Another question from Ferdinand Griffin, and the question goes, how can the hemovigilance be done in the regional blood banks for safe transfusion services? How is it significant? Or how is it of significance? Yes. How is it of significance? Back to you.
So vigilance, I know Hanta last year we did am I still audible? I know last year we did a webinar on hemovigilance, and we might also repeat this year because it's a key topic, and we really need to champion towards that until we achieve this as a country. Hemovigilance is key. The reason why it is significant is the one that is concerned with the safety, administration of blood products, and blood components. So it covers all the steps right from the donation stage to the screening, to the lab, and to the administration of blood and follow-up of this patient. For some transfusion reaction might not be immediate, but how do you deal with them? You should have a reporting system. Is the patient even able to report that I've received this particular blood? I've received a transfusion in the past 2 weeks, and then after that, I've been developing fever or any kind of anaphylactic reactions. You see, they might not be able to know until that point that we are come up with an important hemovigilance system. They're able to report what they are seeing, and then a follow-up can be done. So again, that's why hemovigilance system is very key, because the patient might even receive blood today. They are discharged after 2 weeks. Then 2 weeks later, they develop fever. Maybe they have gone back to the villages, like a patient is in Oma Bay now, for example. I've used in a patient is in Suba. With them, they will treat that as malaria. They'll go to the nearby dispensary. That near dispensary is treating malaria. That is not there. Maybe they are not even testing whether it is there or not. They are treating that malaria, but in real case, it is a delayed transfusion reaction. So by the time we are realizing the jaundice are apparent, you see. So such case, a hemovigilance system will help us develop, because it will involve donor education, the personnel that are involved, and also patient education, as well as the medical personnel, and also active follow-up. It will also allow collaboration between the clinicians, the medical officers, the nurses, the lab team, so that we are able to review our activities. Another thing that the hemovigilance will do, each and every hospital that is having a transfusion lab or having a transfusion setup, transfusion cannot be done in any hospital. So this the system will ensure that this transfusion hospital, they have got hemovigilance committees within that hospital. So what the hemovigilance committee will do, they'll be able to review the events or their transfusion chain, the entire chain. Look at, were there any adverse events that were reported? Were there any transfusion reactions that were reported? Were there any near miss? And then corrective actions are taken, and they are able to improve their system. Was there any life-threatening event? If there was any life-threatening events, it is escalated all the way to the to the national level. And then the national level will be able to, if something that requires change of policy, then it can be changed at the national level, then it trickles downward. So that's why the immovigilance system is very significant.
Very well. The very last question here is from Byron Odhiambo, and the question is, please comment on women donors who are on periods. Are they eligible?
Sorry, I was muted. Sir. So I was saying for the females who are on their menses, then you'll do an assessment. What is their HB? What is the flow like? Is it abnormal? Because in real sense, we're supposed to define. But if they are not experiencing abnormal flow, which means there is no menorrhagia, there are not excessive loss of blood, and they have got enough HB of above 12, then you can recruit.
Thank you so much. Thank you so much. Our time is up, and so I will bring you back, Mr. Francis, so that you do your parting shot as we wind up this presentation today. Welcome back.
Yeah, so the last word of our presentation summarize it all. Let's keep an eagle eye on TTIs. Because as we have seen, TTIs is very, very instrumental in administering of safe blood. So the only way we can be sure that the blood that we are giving is safe to the recipient, and we are not, it is very sad that a patient walks in the hospital, HIV negative, hepatitis B negative. Let me just go with HIV, for example. I'm just using it as an example. At least syphilis, there is treatment, but let me go for HIV. HIV is a long life disease. So if this patient walked negative, but then they come out of an hospital positive of HIV simply because of a transfusion, so that is an injustice to that patient. And if they sue us, they are eligible to be compensated accordingly. So it is only important that we keep an eye, because we are the watchdog. The lab is the watchdog in transfusion. Transfusion, actually, everything start and stop at the lab. Even if there is a reaction at the ward, they will still come back to the lab. So if we don't keep an eagle eye on this, then we'll end up exposing our or putting our patients at risk. So all the best, everyone. I'm looking forward to more interactive session. We'll still have more session on hematology and transfusion, and we'll keep on learning on various aspects. And those ones that you feel that we need to redo, we might consider redoing them. Maybe you can just post that request to Hatha and to the LMSK group, that this topic that interests us, maybe we might redo it in future, or we can schedule to see how we can even improve it better. So until next time, have a good evening.
Thank you so much, Mr. Francis, for finding your time to come and share knowledge with your colleagues here, the medical lab fraternity in this country. Also, thank you, our participants, for registering and coming on board and listening throughout the 1.5 hours since we started this presentation. I hope that the kind of knowledge we're impacting here is helping us in our day-to-day running of our laboratories. We still urge that we continue registering and attending these presentations so that we keep learning, because medical laboratory science is dynamic and it keeps changing every day. So if we decide to keep on learning and adding more knowledge, then we will be more equipped and competent in running our labs. Otherwise, from Lab Medicine Society of Kenya, we are grateful and we invite you again for another webinar tomorrow. My name is Athay Mari, and I was your moderator today. See you and have a good evening.